Good evening, ladies and gentlemen. We have come to the final teaching capsule for the conference 2020 of the Ceylon College of Physicians. And this is teaching capsule 8, and it is themed on acute stroke care. And we are privileged to have with us Dr. Padma Gunaratne. She is a senior consultant neurologist who was also president of the Ceylon College of Physicians, the Sri Lankan Association of Geriatric Medicine, many neurological associations, as well as she is the president-elect of the Sri Lanka Medical Association. And I would like to invite Madam to deliver her teaching capsule on acute stroke care.
Thank you, Shehan. At the outset, let me thank Dr. Ananda Vijayvikrama and the academic committee for inviting this very important topic in the academic program, and also for inviting me, for including this timely topic in the academic program, and also for inviting me to talk on this topic. So over the next 50 minutes, we would be trying to learn on the management of acute stroke care. Now, when we talk on stroke, stroke is a very important topic, and we know that why stroke happens, the etiopathogenesis, I mean, it's purely or mainly because of atherosclerosis, and thromboembolism is the main reason. And then you know that a good number of significant proportion of strokes happen because of cerebral infarctions, and a smaller percentage of strokes happen because of hemorrhages. So if you see it as a proportion, about 85% of stroke are caused by ischemia or cerebral infarctions, and about 15% is caused by cerebral hemorrhages, and another smaller percentage is subarachnoid hemorrhages, I mean that which we do not discuss under the same heading. Once you had a stroke, there is a very high risk of recurrence because of the improvement over last several decades, because of the improvement of care all over the world. The risk of recurrences have been brought down to a significant extent. So altogether, the incidence of stroke is decreasing, particularly in developed countries, mainly because of the management of risk factors, particularly the high blood pressure, management of high blood pressure, and the introduction of statins, as well as because of the better care given for stroke patients. I mean, so that the recurrences are reduced. So once you had a stroke, we know that there is a risk of having another, there is about 20% risk of having another stroke. So why do we say that this is an important topic that we all as physicians have to be familiar with? Is because, I mean, all over the world, it's the second leading cause of death. It becomes second only to the ischemic heart disease. And say, as per Sri Lankan literature, the prevalence of stroke is about 1 per 100 in our community. And if you think of the leading hospital where many of us have been trained, there is about 5.6 admissions of stroke per day to National Hospital. And at the same time, there is an equal number of stroke admissions to Colombo South Hospital. And if you take Kandy Hospital, and it may be because that there are many other satellite hospitals, there aren't many other satellite hospitals developed. There you get about 7 admissions of stroke per day to Kandy Hospital. So that itself gives you a sort of indication to say that why we need to be familiar with the management of acute stroke care. So then if we pay attention on the death rate again in Sri Lanka, now you know that about out of the registered deaths of stroke, only 30 to 40% of deaths, they do not, 30 to 40% of stroke deaths do not happen in hospitals. So majority of data that we have are on strokes that have died in hospitals with regard to death. And having said that, In 2013, stroke was the third leading cause of hospital deaths in Sri Lanka, and in 2014 it became the fifth leading cause, and 15 and 16 it was the sixth leading cause, and in 17 it further dropped to seventh leading cause of death. But again, we saw that in 2015 it was the fifth leading cause of death in hospitals. But we know that many stroke deaths do not happen in hospitals, so that this is not the real figure. If we try to apply that to our ordinary community. When we talk on stroke, it's important that we have a few, basic knowledge on few important areas. I have already said that the basic etiopathogenesis, but then if you think of why do people develop strokes, we talk of this classification, the TOAST classification, where we discuss the etiology. Based on the etiology, the stroke is further classified. So there are three important varieties of stroke that we need to be familiar with. One is the large artery atherosclerosis, the second is cardioembolism, and the other is the small vessel occlusion or small vessel disease. And the other two are the rare ones, the strokes of other determined etiology and stroke of undetermined etiology. Out of those, we know that the most common is the large artery atherosclerosis, and particularly if it's in the anterior circulation, middle cerebral artery, and if it's in the dominant hemisphere, that is the most disastrous type of stroke. And in case of cardioembolism, there are many known causes, and they are, you get like large artery atherosclerosis, fairly big emboli blocking large arteries, whereas in small vessel occlusions, generally, their prognosis, is generally related to high blood pressure, long-standing high blood pressure, and their outcome is much better than large artery atherosclerosis. So if you look at this picture, you understand what large artery is. You see basilar artery, internal carotid artery, and then you see the M1 and M2 segments of the middle cerebral artery, and then you have anterior cerebral and so on. So generally, these are the vessels that would contribute for large artery disease of the brain. Now, when we talk on acute stroke, say in case of a stroke, I said that 85% of stroke happen because of infarctions. So our talk, or at least 90% of my talk, would be concentrated on infarctions. So if in case of infarctions, as the vessel is occluded by a thrombus, you know that there is ischemia to cerebral tissue. So over the minutes, you would see that there will be, excuse me, is there a way that I correct this? Over the minutes, you will see that there will be the infarcted cells in the core, and then around that you have this ischemic penumbra that has been caused by the, as a vessel is occluded, there is collateral flow, and the perfusion pressure of those collaterals are not good enough to maintain the cells functional. The cells are in this around area in the penumbra. The cells are viable still for another few more hours, but they are dysfunctional. So they have contributed to the symptoms, but unless the cells are rapidly reperfused, the viability would last only for a few more hours. So if we do not open up the cells, open up the vessel, the majority of the cells in the penumbra would join with the core over the next few hours, whereas a smaller percentage of cells would join with the normal, with the collateral circulation. But if we do open the occluded vessel immediately, then majority of cells in penumbra would join with the normal tissue, and it's only little amount of cells that would join with the core. So based on that concept, it becomes extremely important that we think of reperfusion, which has to be done fairly fast based on, I mean, every minute counts, time is brain, and see, for every minute that we waste, millions of cells die. Therefore, the reperfusion is the mainstay of treatment for cerebral infarctions, acute cerebral infarctions, if they arrive the hospital early enough for us to intervene. Now, before when we think of reperfusion, the hospitals has to be ready. The programs have to be established. So there are a few important steps in the program for management of acute stroke program in a hospital with the intention of providing reperfusion services for patients. So there has to be in the program, there has to be the facility for pre-notification for you to do all these things. There has to be a fairly good program on public education, particularly with regard to diagnosis of stroke, then public education on knowledge on strokes, and then public education on how to act if a person has faced with a stroke. So the hospital has to be ready with a pre-notification of informing that a stroke has happened in somewhere and the patient would be brought to hospital immediately. So there has to be tools that has to be in place, the guidelines, pathways, the training of the staff is very important. The training has to be there for all categories of staff, including the nurses and the minor staff, and particularly for doctors, the training on NIHSS, that's the assessment of the stroke patient, National Institute of Health Stroke Skills. These many types of training has to be done before we establish a stroke care program in a hospital. There has to be a single call system to inform the entire stroke team that's available to manage the acute stroke patient, and the patient there has to be the facility to transfer the patient directly from the OPD or triage to the CT room. CT has to be located in the OPDs itself, and in the CT room that the CT department should give the highest priority for the acute stroke care patients, and the CT has to be done within 25 minutes of arrival to the hospital, and the whole process should not take more than 45 minutes, and one should be able to give the drug that we describe as the thrombolytic agent to dissolve the clot within 45 minutes of arrival to the hospital. There are many lab tests that has to be carried out. Initially, there were many lab tests that were recommended before commencing the thrombolytic agent. But as at present, the only blood test that we do for patients before thrombolysis is blood sugar, and then blood sugar that could be carried out even in the emergency department unless the patient is suspected to have any sort of coagulopathy or on an anticoagulant like warfarin. And then once you have done all these things and once you are happy with the eligibility of the patient for thrombolysis, you have to commence the drug immediately. And what is most important to emphasize is that the time is the most important thing, and that one has to act fast if we are little concerned of the quality of recovery of that patient. For us to do all these things, the skills in diagnosis is important, and the most important way to diagnose stroke is by taking the history, by eliciting that the onset of clinical features are acute. How do we elicit that it's acute is by asking the patient, what were you doing at the time that you developed symptoms? If one could say that while I was doing that, then we know that the patient's symptoms are acute, and then you see whether the patient is with neurological manifestations. And then you could ask the patient, when were you last seen normal? So you have to record the time, not based on how many hours behind, but based on the clock time. So you don't say that 2 hours ago, but you say that at 9 o'clock patient was well, by 9 to 10 the patient developed these symptoms. And then rapidly you need to do a focused examination. And we'll be talking what could be, what you need to look for. And then it's important that one has to keep in mind stroke mimics, to look for stroke mimics, but then suspicion of stroke mimics should not delay you thrombolizing patients, because the risk involved with thrombolizing the stroke mimics is very minimal. Therefore, all the time you give the benefit of doubt to the patient while you take your maximum effort to exclude whatever is possible with regard to stroke mimics. Then the obtain relevant history in the protocol. You need to pay attention, because that there has to be protocols ready, available in the place where you evaluate the patient. So you have to send the patient through the protocol. You need not study each and every point of inclusion and exclusion criteria, but protocol has to be available in the place that where you evaluate the patient. So you have to obtain history, particularly with regard to anticoagulants, being on anticoagulants, and recent history of arterial puncture, medical conditions, and recent surgery, and so on. The possible stroke mimics are hypoglycemia, seizures, metabolic conditions, and migraine with aura. So in the examination, the first is the airway, breathing, and circulation. And if patient is seriously ill, if the JCS is about more than 8, sometimes there is a place for you to ventilate, need for ventilation, ICU care, and the ventilation. So it's important that you document everything carefully before you paralyze the patient for ventilation. Once you know that a patient is with a stroke, you need to assess the patient's speech to see that whether he could follow your commands, and then look for eyes, whether eye deviation or vision, whether there is hemianopia, and limbs, whether there is paralysis. And at the same time, it's very important that you check for blood pressure. If blood pressure is high, 185 by 110, if you are intending to thrombolize that patient, then you know that you are unable to thrombolize unless the blood pressure is brought down. So even in case of hemorrhage, your management includes bringing down the blood pressure. So therefore, if the blood pressure is more than 185 by 110, and then if you intend to thrombolize that patient, if you try to start drugs, IV drugs, to lower the blood pressure, that at that time itself, that would be perfect. And then document in IHSS by examining the patients fairly fast, because that becomes important. In the NIHSS, there are 11 items. Again, one has to have the experience in doing an evaluation using the NIHSS, and the score is 0 to 42. If there is 0, no symptoms, 1 to 4 is very minor stroke, 5 to 15, moderate, and 16 to 20 is moderate to severe stroke. And if it's more than 21, then they are with worse stroke, severe, very severe strokes. It's important that you have some idea on clinical classification, OCSP classification. You have the strokes in anterior circulation, posterior circulation, and the lacunous strokes. And in anterior circulation, you have hemiparesis, hemisensory loss, and then there may be either hemianopia or loss of vision in one eye, and the other cortical problems like dysphasia and the involvement of other cognitive functions. And for posterior circulation, the occipital lobe, the vision and brainstem problems, and the cerebellum. And if it's the lacunar syndrome, it could be, just pure motor, pure sensory, and so on. So it's important that, because based on that, you decide whether this is a small vessel disease or whether it is large vessel disease. And you know that small vessel disease patients, they respond better for antithrombolytics more than for large vessel disease, because it becomes important for your further continuation of management. So now it's the management commence, and then for management, there are a few areas. In the most important is acute reperfusion. For acute reperfusion, there are 2 areas that we would be discussing, and the one is chemical thrombolysis with RTPA, and the other is by mechanical thrombectomy with a retrievable stent. And at the same time, it's important that we maintain adequate hemodynamic, manage the patient's hemodynamic status for viability or the supply of collateral flow, for viability of that penumbra. So it's important that we maintain the patient's blood pressure and to maintain the perfusion pressure and to not to lower the blood pressure immediately, and also maybe that by giving some IV fluids that the perfusion could be better maintained for the penumbra. With regard to position, there is not much of an agreement, but you have to position in a way that patient does not get aspirated. The blood pressure management is very much individual and the time of the stroke, as well as whether it is hemorrhage or an infarction. For the infarctions, there are 3 areas for blood pressure management. One is if you intend to thrombolize the patient, you lower the blood pressure less than 185/110. At the time that you start thrombolytic agent, blood pressure has to be less than 185/110, and you need to maintain it 180 and 105 for about another 24 hours. But then if you have passed the therapeutic window, then again you maintain that you do not immediately lower the blood pressure unless there is emergencies, the hypertensive emergencies, and you gradually lower the blood pressure. And then if the patient is with a hemorrhage, you may reduce the blood pressure. You manage best that you manage the patient in ICU, and you may lower the blood pressure up to about 160/90. And there is some data for the benefit of managing lowering the blood pressure in the acute stage or for cerebral hemorrhages. The blood sugars avoid both hyper and hyperglycemia, and it has been shown that the intensive management of hyperglycemia with IV insulin or the insulin has not shown any benefits at the 3 months outcome. So if we could maintain the blood sugar around less than 180, that has to be all right. And see that the patient's temperature is managed and they prevent infection. Take precautions to see that we prevent infections. And if once the patient is moved to ICU, management with regard to cerebral edema becomes important. And in the long-term management, for the patient is best managed in a stroke unit, and the early recognition and treatment of systemic complications becomes very important. So we need to anticipate the complications and manage them then and there before it happens, so that the patient would cooperate with the rest of the stroke team for continuation of the rehabilitation. So dysphagia assessment within first 24 hours, as you see the temperature spike to start on antibiotics, the managed heart failures, arrhythmias, they all become equally important even in the acute stage of the management. Now, why do we use thrombolytic agents? Because there had been many studies, randomized control studies, to show the benefit of IV recombinant tissue plasminogen activator when given within 4.5 hours of onset of symptoms. The benefits have been shown again and again and again. So this is the findings of the meta-analysis, and all these studies have shown the benefits of using IV RTPA, and now we have been using RTPA for more than 25 years, so that if there is a hospital where a CT facility is available and a physician is working, and I think that's the place where we could implement a program for thrombolysis within the first 4.5 hours from onset of symptoms. Here are the places as at present that IV thrombolysis is available. It's important that physicians be familiar with these centers. There are 17 centers as at present in Sri Lanka where they offer the thrombolysis for stroke patients. So if you come across the patient, acute stroke, immediately need to direct that patient to the place where they practice IV thrombolysis in that hospital. Now once the patient has reached the hospital and has quickly evaluated, the next important step is to do a CT scan. It becomes extremely important that CT has become extremely important because it is impossible for us to manage a stroke without a CT scan. There have been so much of advancement, radiological advancements in the neuroimaging that has made so much of a difference to management of stroke as at present. So you'd be sort of learning, I'll be spending few more minutes over the neuroimaging with regard to stroke over the next few slides. So you do the CT scan immediately by knowing that infarct takes time to appear. So if the CT scan is normal, you are happy because then you know that it is an infarct because CT is very sensitive to pick up hemorrhages. So if there is no hemorrhage, then you are happy to continue with the IV thrombolysis of that patient. But then at the same time, it's important that you train your eyes to recognize the early changes of cerebral infarctions. There could be attenuation of the image. This is all the time you have two sides so that it's easy for you to compare. And there is the attenuation of the lentiform nucleus and the obliteration of the internal capsule, and then this insular ribbon. There is the lack of gray-white differentiation of the insular ribbon and the cortical ribbon. There is lack of differentiation of the gray-white differentiation in the cortex. So they all are very early features of cerebral infarction, and one should train eyes to recognize these early changes and to decide, because once the changes have happened, say as there is an infarction, cerebral ischemia, there is movement of the extracellular cells move into the intracellular compartment, so that appears as an infarction. Once that appearance has established, then that becomes an irreversible change, so that you know that there is infarcted cells. So initially this change that was seen was very useful for us, and to say whether it's a severe stroke or not, because if more than 1/3 of the cerebral cortex was affected, then we knew that the patient's stroke was a burst stroke. But then we realized that 1/3 rule was not a reliable rule, so that they came up with the aspect score, where the areas of the brain were given marks. There were 10 areas in the brain: M1, M2, M3, M4, M5, M6, up to M6 in the cortex, and then 1 mark for caudate, and then the internal capsule and the lingular cortex, and the 6 areas. So based on that, you give 10 marks. And say in a normal person, if there is no infarction, then you give 10 marks. So aspect score 10 is a normal brain. So if one area is affected, then you make it 9 marks. So likewise, you could decide, give the aspect score, and based on that, you could say that how worse the CT changes of the cerebral infarction is. So here I'm trying to show you your eyes on cerebral infarctions, so that if any CT shows this type of changes, then you know that this is already infarcted. Our interest is on penumbra, which is ischemic, and our interest is on reperfusion and to salvage the cerebral tissue. So we have to have a means of recognizing whether there is salvageable tissue left in that brain before we do any intervention for reperfusion. Because if you open up a vessel for this type of an infarct, then it's more likely that you would precipitate the secondary bleeding. Post-perfusion, reperfusion bleeding would be very likely for this type of a massive infarct. So it's important that we have means of establishing whether there is salvageable cerebral tissue. This is another important sign. It's called the dense middle cerebral artery. If you see that, then you know that there is a clot in the middle cerebral artery, and this is going to end up as a burst stroke. So that, and then you know that that is unlikely to be resolved with thrombolysis. Immediately that patient would need the removal, clot retrieval or thrombectomy for recovery. And this is how a hemorrhage would appear. And in case of an acute hemorrhage, it is very smooth, diffusely hyperdense area, so that it's very easy for you to recognize hemorrhages. Then the CT has many facilities that has made the stroke care very glamorous as well as very useful. With CT, it's possible for us to trace the vascular tree by doing a CT angiogram. So it needs contrast, but gives so much of information that are important for management of both ICH as well as ischemia. For ICH, if there is arteriovenous malformation, it becomes useful, and even for spot sign, I would be talking in a little while if I have spare time. And with regard to ischemia, say if we have done the cerebral angiogram, the CT angiogram, it would show us the presence of location of the thrombus, whether it's a large vessel disease, and if so, that whether there is a thrombus, how is the collateral, whether there are a lot of collaterals, and it gives us information with regard to extracranial, whether there is the stenosis of the carotid as well as the aortic disease, and also of information with regard to carotid web and other vasculopathies. So if we have facility based on where you work, based on facilities, you could further advance the management of stroke by continuing with the CT angiogram. For an instance, now this is the CT angio and this is blood vessel, and you see that this is completely occluded. So if you see this type of a thing, it's unlikely that we would thrombolize. Even if we do thrombolize, the limitation is that it would not get dissolved. Whereas if you see this type of a thrombus, you see that there is permeation of contrast through that thrombus. So even if it's a big thrombus, it's possible that there could be certain amount of recanalization in that thrombus. So there are many details that could become useful in the management when we perform a CT with the expertise who could read the CT angiogram. And also it gives the information with regard to collaterals. I told you that CTs could be done as multi-phase CTs. Immediately within seconds, they do many cuts and they do dynamic studies and trace the vascular trace. See, if you look at this one, that it's phase 1, phase 2, phase 3. Here in this one, you see that this is the ischemic region and there is delayed filling of these vessels in this one. And here in this one, you see that this is delayed washout. This is affected side. Here in this one, you see that there is no filling, no washout. So this is the worst one, and the patient had the severe stroke. There is no collaterals. And whereas in both these ones, there's good amount of collaterals, so that if you open up the vessel, the recovery would be slightly better. And again, with the CTs, that we have the facility called CT perfusion, which let us know whether there is salvageable cerebral tissue. If you get this, if you remember the aspect score and look at this in M4, M5, M6, there's no vasculature in M6, and keeping with that on the CT, you see that this is infarcted tissue. And then in the perfusion image, it is infarcted. Whereas in M5, there is the delayed perfusion as well as delayed washout. And M4, there is early washout. So in both these areas, this is somewhat moderate amount of ischemia. This is with mild ischemia. And keeping with that, if you open up the vessel, you can preserve good amount of cerebral tissue. And the perfusion studies also gives the same amount of information. So there are many, as it is that the CT is the best type of imaging investigation for management of stroke, because it has many facilities that could be made use for in the management of acute stroke. So for CT, perfusion is obtained after IV contrast and multiple images over time, and they do summation of time resolved images, and it involves higher radiation, but it's very important to predict mismatch by estimating the degree of blood flow. So it gives us the indication whether there is any salvageable tissue, so that the reperfusion has to be done immediately. Few words on MRIs. You know that there are many ways of MRIs could be done. Here is the T1 MRI, T2, a FLAIR, and a contrast study. But if we know that the patient had a stroke, all the time to look for infarction, what we do is diffusion weighted images. In diffusion weighted images, you see this type of an infarct that appear maybe even within 30 minutes. So sometimes patient had a stroke TIA and resolved after 1 hour. And if you still do a MRI with diffusion weighted image, and you still see these infarcted cells. So these cells are infarcted and they are not salvageable. So it very clearly shows whether there is infarction or not. Again, the MRI gives the facility for MRA and the FLAIR images. So this is diffusion weighted image that shows the acute infarct, and the MRA shows that the middle cerebral occlusion, and the diffusion weighted image, this takes about 3 hours to appear. So this is another way that you could look at the image. This would last for a longer period. So the appearance of the difference of time taken, this appears in about 30 minutes, and this takes more than 3 hours. So if there's a person whose DW image is positive and the FLAIR image is negative, then you know still that the stroke has happened over the last few hours. So we make use of that concept in the management of wake-up strokes that I'll be talking in a little while. So again, a CT scan, infarct, a FLAIR image, infarct, and diffusion weighted image, a hyperacute infarct. And if you see this type of image, you see that it's a cortical infarct, bilateral and cortical, and many vascular trees. So if you see this type of DW image, then you know for certain that the source of infection is cardioembolism. So now you have done the CT scan of the patient. Patient is ready, and you need to evaluate for eligibility for thrombolysis. There are inclusion criteria. Basic inclusion criteria are it has to be a ischemic stroke with disabling neurologic deficits. Symptom onset has to be within 4.5 hours. The earliest is the best. And for wake-up stroke, I have said that I'll be talking in a little while, and the age more than 18 years. And then there are many exclusion criteria. The protocol has to be in place at the place where you work. And there were many exclusion criteria in the original study in NIMS. But then much later, many of those were removed because of the effectivity, the benefits that one could gain out of this important treatment. So if a patient has had severe head trauma, spinal surgery within last 3 months, ICH, and if the patient is with suspected SH, and the GIT malignancy, recent GI hemorrhages, all these are sort of clear contraindications for thrombolysis. In addition to that, if blood sugar is more than 50, if blood sugar is less than 50 or more than 400, then you need to immediately control the blood sugar. Sometimes it may be hypoglycemia that's responsible, or hyperglycemia that has to be treated immediately. If blood pressure is high, again, you have to treat and then need to thrombolyze. And if the patient is on warfarin, your INR has to be less than 1.7 for you to thrombolyze. Generally, you do not wait for any other blood test unless you suspect the patient to have a coagulopathy. Generally, it's only with random blood sugar. If that's normal, then one could embark on thrombolysis. There are relative contraindications that you need to take into consideration case by case. If patient is rapidly improving symptoms, initially thought that it's not of use, but then now the studies have shown that all patients who rapidly improve symptoms are left with some infarcted cells. So if every cerebral cells is important for functions, so that if you do thrombolyze, then the patient, you would salvage cerebral tissue. So, and then unruptured cerebral aneurysm, ischemic stroke, major extracranial trauma, seizures at onset, pregnancy, they all are relative contraindications. Then there are a few more exclusions if the patient is with the therapeutic window within 3 and 4.5 hours of symptom onset. If more than 8 years, you do not thrombolize. If otherwise, you thrombolize. If the patient is with a severe stroke, and if patient is on anticoagulants regardless of INR, if patient with diabetes and ischemic stroke, then in all these situations, there is a higher risk of hemorrhage. So you better not thrombolize because the NNT number needed to treat in that category is fairly high. So the dose is 0.9 per kg, 10% is given as IV bolus and the rest is given as IV infusion. And if you do not continue with further management, patient has to be sent to ICU, monitor every 15 minutes for 2 hours, every half an hour for another 6 hours, and hourly for 24 hours, and a repeat CT scan. And you do not pass gastric tubes or catheters, and you do not commence any antiplatelet agents within that 24 hours and the repeat CT scan. But if you continue, now some of the patients are with large vessel occlusions and there is little bit more that you could offer, and there are limitations of thrombolysis. So if you work at a place that where only thrombolysis facilities available and there is no facilities for thrombectomy, you need to commence the patient drip of infusion and then you ship the patient to a place where thrombectomy facilities are available. Or if you are in a place where thrombectomy is available, then you continue with the angiogram studies while continuing the infusion, thrombolytic infusion. There should not be any delay of commencing IV thrombolytics because that you continue with the further radiological studies. Then there is another thrombolytic agent called tenecteplase, which is a bioengineered variant of RTPA, and it could be given as a single IV bolus. And the studies have shown that it has better outcome, lesser risk factors, and the cost-wise also it's cheaper. So probably that in near futures, then tenecteplase will get into the protocols of cerebral, the thrombolysis of stroke as well. There are complications involved with IV thrombolysis. The main complication is intracerebral hemorrhage, which happens in about 6.4% of patients. But then one has to understand that the benefits so much outweigh the risk, and the number needed to treat to harm a person is 126. So you continue with thrombolysis. The ICH happens more with old age, diabetes, severe hyperglycemia, hypertension, and also for large infarctions. I mean, these are patients anyway who would carry a poor prognosis, and and also it's more likely to happen in large infarcts following reperfusion. So more likely that the ICH worsens the stroke that anyway is destined to be disabling. So you have to keep that in mind, and it's important that if there is a rapid deterioration of consciousness, you immediately have to repeat the CT scan and then to start the patient, immediately stop the infusion and need to treat the patient with cryoprecipitate. And the angioneuritic edema is another complication. The protocol should include management. The management of angioneuritic edema for emergency for these patients, because that tend to occur more often in patients who has been on ACE inhibitors. There are limitations of thrombolysis, the narrow therapeutic window. There are ones that would not come within this period, and there are many contraindications, and in some, particularly with large vessel occlusion, even if you thrombolize, there may not be recanalization. Therefore, one has to be familiar, and all places has to have the facility for endovascular therapy, particularly for large vessel occlusions. There is data for large vessel occlusion, the mechanical thrombectomy with the retrievable catheters. If CTA confirms the patient to have intracranial carotid artery or in one segment of MCA, and mechanical thrombectomy should be started as quickly as possible and should not be delayed to assess the response to intravenous RTPA. So all the time CT angio or MRA has to be done. If the patient acute ischemic stroke patients NIHS is more than 6, and if the stroke is within 6 to 24 hours also, then CTA and MRA become useful. So by doing thrombectomies, I mean, the number needed to treat to get one better outcome is within 90 minutes is 3.6. And if it is within 180 to 270 minutes, it's 5.9 patients. So it's so effective, and if possible, all the time have to offer to these patients who could be left with devastating consequences. Now, in general, the criteria for inclusion for patients for thrombectomies are generally age more than 18, and the NIHS, as I have said, more than 6. And the Van score is for large vessel. That is, if a person has hemiparesis and need to look for vision, the speech, and for neglect, and if those are there, then you know that it's a large vessel occlusion. And the good pre-stroke functional status is a relative thing. They also could be benefited, as PEC score more than 6 are good patients for thrombectomy, and the presence of proximal intracranial artery occlusion and time of symptom onset less than 6 hours. And these patients definitely are going to be benefited, but even for patients up to 24 hours, they could be benefited in certain situations if we have used the tissue clock and have shown that there is salvageable tissue by doing either a perfusion CT or a perfusion, diffusion perfusion MRI. And the mechanical thrombectomy number needed to treat to reduce disability by 1 level in modified Rankin scale is 2.6. And it's quite safe. It could be used even on patients who have been on anticoagulants, even on patients who are on NOACs, I mean, who anyway are excluded from thrombolytic programs. There are many others who may benefit from thrombectomies. I mean, I said that if even onset more than 6 hours, M2 branch occlusions, and the presence of extensive changes in CT, large core on CT, acute basilar occlusions, pre-existent disability, all these patients also may benefit. So these are being practiced all over the world because the benefits are sort of very much overwhelming. And then with regard to wake-up strokes, if a person wake up with a stroke, then we do not know when he developed the stroke. And sometimes they are aphasic, they are unable to tell the onset of the stroke. So in that type of a stroke, then there are studies to show how to thrombolyze patients. So we said that thrombolysis could be done in 2 situations. One is within 4.5 hours from onset. The other is that if in a wake-up stroke, I mean, there are 2 studies that if your DW is positive and flare negative, then again we know that it is acute stroke. And in that type of a situation, if your DW positive, flare negative, then again you could thrombolyze in wake-up strokes, or even in others with 4.5 hours to 9 hours, if you have shown by having done the perfusion CT or MRI with diffusion perfusion studies and have shown that there is salvageable tissue. And if you do thrombolyze, again, the studies have shown better functional outcome at 3 months. This is how the diffusion, and this is a diffusion weighted image, and here is a flare image. Then you know that this is acute stroke because the flare is negative. Diffusion for positive, flare negative, it's an acute stroke, less than 3 hours of symptom onset. And here diffusion positive, flare positive, diffusion positive, flare positive, then you know that there is, it's unlikely that it to be very acute within the therapeutic window. Then there are studies to show the benefits of endovascular therapy, again up to large intracranial artery occlusion, within 6 to 12 hours of symptom onset as well. If you have used the tissue clock and if you have confirmed mismatch between the clinical severity and the ischemic score, and that again indicate that there is penumbra, salvageable tissue, and then if you do thrombectomy, the studies have shown the benefits, as well as in the diffuse study, they showed that the onset from 6 to 16 hours after symptom onset. And if there's a mismatch and there's penumbra, then again, if you do thrombectomy, the number needed to treat was 2 to 4 patients to get one better recovery. So by DW imaging or CT perfusion criteria, we could define the salvageable penumbra so that we could establish recanalization. So I'm trying to take you through again when you get a stroke, say if patient is within up to 4.5 hours, you could do IV RTPA, and then up to 6 hours, you could do mechanical thrombectomy. You need not do any of the perfusion studies to do any of these studies. And then beyond 6 hours, if you have shown a mismatch using the tissue clock, you again could do thrombectomy for large vessel occlusions. And in addition to that, if you have shown the mismatch between the flare and the DW in wake-up stroke, again, there is a place for IV thrombolysis. This is the catheter that is being used is called solitaire catheter. And there is a place for you to do posterior circulation stroke, basilar artery occlusions. IV thrombolysis could be useful, as well as for mechanical thrombectomy. Even if there's no data, many do practice as the treatment is effective. And for patients with NOACs, I have already said that they could undergo thrombectomy procedures. So let me conclude my presentation by telling you that acute stroke medicine is an art and science that involves rapidly assessing patients' clinical and imaging information and making clinical decisions in a timely manner. Thank you for your patient attention.
Thank you, Madam, for that excellent presentation. We would like to entertain any questions if the audience, the viewers have. There are a couple of questions that you can see. Sorry. I would like to ask you a question, Madam. If one is quite away from a center where there is thrombolysis is available, what kind of clinical pearls would you give the audience in managing a patient in acute stroke care in a center where there's no thrombolysis or any kind of high fidelity treatment facility?
Now, if we think of, Sri Lankan setting, the basic CT scans are located in every district in Sri Lanka. When we did studies, our stroke patients, almost all of them have undergone CT scans in hospitals. So the doctors are aware. So I don't think that we discuss management of acute stroke without a CT scan. So it's a very basic requirement to do a CT scan. So the CT definitely tell us whether it's a hemorrhage or an infarction. And then in the acute stage, there are many things that one could offer for that. The airway breathing circulation, we have said, the managed blood sugar, the positioning, assessment of the swallowing is something that does not happen at all. And then the managing patients, those days, it's not like, those days now, because that we see so much of recovery with the rehabilitation of these patients, it's extremely important that even if you do not thrombolyze, by looking at the acute stage, it is extremely difficult in the acute stage itself to predict what the outcome would be. So you all the time have to give the benefit of doubt to that patient, and if facilities are available, and in case if the GCS is more than 8, you should offer that patient intensive care and avoid aspiration, and there is a lot that one could do. And then we have already discussed on blood pressure management. And if it's a TIA, there is a place for, or non-disabling stroke, there is a place for loading place for antiplatelets, you may give non-disabling stroke or TIA, 300 milligrams of clopidogrel and 300 milligrams of aspirin, a loading dose. And then you continue with the 2 drugs for 3 weeks. And after that, continue with 1 drug. And also there may be benefits by giving a fairly high dose of statins in the acute phase. I think those would be the important points in the acute management.
Madam, you rightly mentioned about the management of blood pressure, not to lower it because it can have deleterious effects. With regards to the choice of an antihypertensive, what is the modern, the up-to-date consensus of the agent that has to be used? If it is oral medication, if it is a hypertensive emergency, what kind of intravenous agent as well?
Now, the intravenous agents are used, say, if you are with a hypertensive emergency, that's dissection and heart failure and so on. If otherwise, if we consider the stroke per se, there are 2 indications. One is if the patient is eligible for thrombolysis, and if blood pressure is more than 185 by 110, then we would use the best drug that is being recommended is labetalol. So that is the sort of, but then if labetalol is not available, any of the other drugs, generally I know that National Hospital use nitrates, or if otherwise hydralazine. So based on whatever is available, more than the drug, that's the level of blood pressure lowering that would be important, and the monitoring the patient in the ICU setting and adjusting the dose would be the important thing. And also for hemorrhages, if the blood pressure is very high, and you could admit that patient to an intensive care unit and then lower the blood pressure to about systolic of about 160 in the ICU setting.
We have a question from one of our viewers. I think you spoke about this in your talk, but I think it will be apt. If the INR is more than 2 in a patient who is on warfarin, can one proceed with mechanical thrombolectomy due to bleeding risks?
The mechanical thrombectomy carries a very minimal amount of risk. It is the benefits so much outweigh the risk, so that the INR is not a big requirement for mechanical thrombectomy. If INR is more than 1.7, you do not thrombolyze. INR has to be less than 1.7 to thrombolyze. But for thrombectomy, the advantage is that even on patients that who are on NOACs, you can't thrombolyze, but you could do thrombectomy. Even on patients on anticoagulants, you could do thrombectomy. So INR 2 is not a contraindication for thrombectomy.
Are there any management differences in managing minor strokes, in particular in subtypes of minor strokes?
Definitely, there are management differences because there is so much of advances that has happened in large vessel occlusions. So thrombectomy is for large vessel occlusions. And generally, it's if it's a large vessel occlusion, we would more carefully look for carotid source of thromboembolism, or if there is nothing that we could found, we do continue even with the Holter to see that whether there is cardioembolism, because those are large emboli. So there are a lot of differences, and large vessel occlusions are a subject by itself.
You spoke of imaging of the neck vessels, magnetic resonance imaging. What is the place in comparison to magnetic resonance with regards to Doppler studies, just simple arterial Doppler studies?
I think the magnetic resonance image is very convenient because if we did the at the same time, say if we did a MRI brain, and then at the same time you could do a magnetic resonance imaging of the neck, so that you know the patency of the vessel. So that gives a very sort of easy way to find out whether there is carotid occlusion. But it is costly and it is not available and sort of a little cumbersome, time consuming, and MRI is not a must for all patients. The advantage of the duplex is that it gives us the degree of stenosis. They could, it's non-invasive and it's available, and it gives us the degree of stenosis. So that's a sort of, only thing is that when we do duplex studies, that we have to do it within, I mean, if you want to get the benefits of the endarterectomy that is recommended, if there is stenosis more than 70%, you have to do it fairly early. If we do it about months later, then there are no benefits of that endarterectomy. So I think duplex is good enough in experienced hands, and it gives us a good indication of the degree of stenosis, provided that it's available on time.
Any final question? Any words of wisdom with regards to management and evaluation of a patient coming with as a labeled as a young stroke?
With regard to acute management, there is, I mean, say, thrombectomy, thrombolysis, there is no data experience with regard to any of these on young stroke. So I think one will have to decide then and there based on individual patients. But then there are many other possible underlying reasons. All the time when you get a stroke, even if you have examined, investigated the patient to your maximum, still what that means is that the patient has, and if you have not found a reason, what that means is that the patient has a reason, but you did not find the reason. So there is so much of room for investigations to find what could be the underlying reason, sort of particularly for young strokes more than old stroke. If otherwise, rehabilitation and the acute management, there isn't much of a difference.
Thank you, madam.
Thank you.
We come to the end of this teaching capsule 8, and I'm very grateful to Dr. Padma Gunaratne for being with us and enlightening us with this capsule on acute stroke here. And I would like to present this token of appreciation to her. Thank you very much, madam. We thank you for being with us over these last 3 days. And we hope that this series of talks and sessions and pre-congresses would have enlightened you in these difficult times. We have had a successful event despite the pandemic effects. It did not cause a pandemonium, although it was a pandemic. And we wish you all the very best. Please join us for further events that we will be conducting online. And we wish you health and peace of mind. Thank you. Bye.